Good afternoon and welcome to our 21st Facebook Live session out of 28. We're grateful to be coming to you from JSC, and Dr. J and I will be speaking today specifically about pain and variables for pain, how we control for it. We'll also include a physical demonstration too to identify where some of these pain receptors are too, and how we really conduct a physical assessment during our office visits together. I'm going to transition to Dr. Jemsek to tell us a little bit more about pain specifically and why we do what we do.
Okay, well thank you, Candace. By the way, you didn't introduce yourself, but most people know you. Candace Willett, pediatric nurse practitioner.
Yes, I am, and I go by Candy too.
It's because you're famous, you should introduce yourself. So, welcome everyone, and again, it's an honor for us to do this. We're happy to do it. We're trying to do regular hour presentations. This one is on pain, which is a complex topic, really deserves 3 or 4 sessions. We just want to go to a clinical, practical point of view, but also there'll be some science and organization in that regard. But first of all, I want to remind everyone why we do this. We do this because we recognize and are more sensitive than almost anyone else regarding the number of people, possibly millions of people, who are suffering, who can't access care for a variety of reasons. And of course, we love our patients that are able to come here, and we do our very best to help them, but we also realize that for every patient that comes here, there's probably hundreds, if not thousands, that cannot attend. And there's a paucity or lack of adequate, if you will, or reliable, dependable Lyme care, because this disease is so complex. It hasn't had the science applied to it. There's been no funding by the government to speak of, and the funding that we've had has gone to the IDSA and been essentially wasted. NIH is doing a variety of studies which will amount to nothing. There's no substitute for studying the patient and making it your life's work, spending time with them, touching the patient, and doing serial interviews and applying your therapies when it's appropriate. And as you know, we stabilize before we treat. So just as a reminder, it doesn't hurt to go through this. This is just one, but very important feature of our criteria for us to go forward. And if you notice at the top, we have POEMS. P is for pain, and that's our subject today. So O is for other, which includes comorbidities, family support, and that sort of thing. E is for endocrine issues. M is for mood. Everything has to be on the playing field and stable enough to treat. And finally, sleep. I can't get anyone better who does not sleep. So we've been working with that acronym for many years, and it's held true. It's held up. There are other criteria. There are other roadblocks, many roadblocks, in fact. But these are the critical ones. And so today we're talking about pain. I think you have an initial question.
I do. What tick-borne infection is responsible for the majority of pain in our patient population?
So to remind everyone, Lyme Borreliosis complex is called that complex for a reason. It's polymicrobial, meaning multiple pathogens. It's multisystemic, invading multiple organs. It's multi-compartmental neurologic, invading all parts of the nervous system, both central, which is our brain and spinal cord, and peripheral, which is our peripheral nerves. And LBC is unlike any disease that mankind has encountered in terms of what it does and how easily it invades the nervous system and infects the neural roots and neural cells. You have to understand this is really happening. You have to get that concept to understand now we have pain because it's damage to the nervous tissue, and it's an adaptive response that we see. So to answer the question, I would say that spirochete's the tip of the spear. Bartonella is very, very important. I think Babesia is mostly a facilitator. Mycoplasma and chlamydia, pneumonia probably invade cells as well, invade the neurons as well. And there may be other secondary pathogens that are involved as well, but it was typically the spirochete and Bartonella, I would say 1 and 2.
Now today what we'd like to introduce to you is the different types of pain. And we'd like to introduce it to you from a perspective of both what we do for adults, what we do for our pediatric population, because it's very important because all ages have pain. And pain specifically can be very problematic for healing and recovery unless it's stabilized and it's managed appropriately. Now to start, Dr. J, we have a question about why do I have so much pain with Lyme disease? And to start,
Right. I think that's best answered by outlining the way pain is transmitted. Pain is an adaptive response to an injury, and as I just said, there's nothing on the planet comparable to what the spirochete and its co-infections can do to the neural tissues and brain tissues. So when we have pain, it's almost always a combination of central and peripheral pain, and of course, if it's peripheral, it goes through the spinal cord, and there are maladaptations there. There are 3 types of nerve fibers, primarily, A, B, and C. A is a larger fiber associated with the muscle, crush injuries, pressure. B is a small internucleal connecting fiber in the spinal cord, and C is our small fiber, which is spread throughout the body in conjunction with the autonomic nervous system, goes everywhere. The nerves go everywhere. And so there are 3 types of pain, and I'd start with nociceptive pain, which these things are more complex and there's overlay, but just to simplify it, nociceptive pain is our crush pain. It's the fastest fiber that we have, so it goes very rapidly to the brain, where it's received in the brainstem, the thalamus, and the cortex. And pain, acute pain is an inflammation is appropriate. If you have a crush injury, you want to put ice on it. If you touch a hot stove and burn yourself, you want to put ice on it and possibly some anti-infectives. And there's a response that's appropriate. But when you have chronic inflammation, and at least a chronic pain, that starts to debilitate the individual in many ways, including major stress, immunologic deficiencies, or reduction in immune responses have been shown. It's been shown scientifically. And all these bad things happen with chronic pain. Some people say, well, I can do the pain. I'm good, I'm tough. I've been dealing with this. And it's true, there are adaptive responses to chronic pain. There are. They can be religious, spiritual, or just, more endorphins, something. And people can just deal with it. But guess what? The immune system does not like it. And just to put things on square here, just to remind everyone, it's all about the immune system getting back on charge. We don't want to treat you forever. We want to treat you to get you better over a few months on pulse therapy, several days a month, whether it's IV or oral. Taper you down, get you on a maintenance program, and put you in a position to heal. And also at the same time, we're enriching your immune response. We're building it up. First it starts as strengthening, and then it gets smarter. And the better you do, the less we do. And that's our goal. Our goal is to put you in a healing state, which may take years, but at least you can do it, because you cannot do it unless the infections are purged. And again, they're steeped in the neural tissue and the brain. And by the way, a lot of the cells will die, and some can be regenerated and some cannot. So in talking about nociceptive pain, the A fiber, we talk about treatment in a second, but that is the A fiber. Then we talk about neuropathic pain, which is like a bad herpes infection, or more appropriately a shingles infection.
yes.
Yes. And it's going to be fascinating. Tingling sensation, burning, stabbing, all of that. And almost all of our patients have that. And almost all of our patients have sensory neuropathy in the feet.
Yes.
And that affects balance, and sometimes it's very painful. So we see that all the time. I'm going to do a little demonstration with Candy later on to show some of the sensory rich areas that are in the head and neck. And which we've discovered over the years, and which are very important in terms of ameliorating chronic headache or neck pain. And then third, we have central pain. Some of you may have heard of CRPS, which is complex regional pain syndrome. This is called allodynia. It is inappropriate pain response to inappropriate signaling. Now, sometimes if somebody squeezes you, hurts you, that's an appropriate response if you have arthritis or if you have inflammation there from the tendons or muscles. But this is when you just stroke somebody like that, like this, little stroke.
Yes, light touch.
Light touch, and that's called tactile dysesthesia. And it means that you're getting an abnormal response to a tactile response, which is very light touch. And that's the corruption of the C fibers in conjunction with the autonomic nervous system. And so we'll talk more about, what happens in the spinal cord and some of the receptors in just a moment.
Sure. And just to kind of review and give examples of nociceptive pain, thinking about it from a PD population, a lot of children might be complaining of, oh, my knees hurt, oh, my legs hurt, I feel achy. Those are things that involve damage to tissue, if you will. Sometimes they even may present with inflammation at these particular joint areas. That's very popular in the pediatric population. When we go towards sensory and we're thinking about the neuropathic pain, the nerve pain, the descriptors like burning, shooting, stabbing, tingling, numbness, sometimes the children are describing it in different ways, like feels like ladybugs crawling on my skin, feels like fuzzy bubbles, feels like my foot's fallen asleep, and they might describe things in different ways, but we could be thinking as a parent or as a provider, okay, something's off, this doesn't make sense, or children indicating they want to be carried because their legs hurt, things are uncomfortable. And when we think about the central pain, the more very damaged nerve endings, just with light touch, is painful and uncomfortable. They may revert to what we call in PD population, no touch me pain. They don't want to be hugged, they don't want to be cuddled, and that's clearly an abnormal if they were once a cuddler and now they're resisting a hug, and that could be by a parent or a family member. That's something to keep in mind. There's many different ways we can treat these types of pain, and we're going to go into that momentarily, but it's always something to be very thoughtful about. In the PD population, observations are really important. If parents can report to me what their children are experiencing, reporting to them, that leads me in a direction of understanding what their type of pain is that they're having.
Good, great. So let's go into treatment, and what you're going to have to say about kids is going to be fascinating, because it's such a unknown. The horizons are really out there, and it's an unknown entity. Not many people do what you do, and have to deal with these kids in pain. I mean, how horrible is that? Can you imagine if you're a parent, and there are many parents listening, I'm sure, your kid's in pain, and you want relief, and you don't want codeine, and you don't want narcotics. What do? And is it connected to another disease? Well, yeah, quite often it is. So for nociceptive pain, we're big on topical therapies. So we have NSAIDs, non-steroidal anti-inflammatory agents, which are now in a gel over the counter. Voltaren is probably the most popular. You can use some of the oral non-steroidals. We'll tolerate that if you do that, but we worry about the stomach. But meloxicam and maybe Voltaren oral would be used judiciously. Sometimes I'll pulse with Toradol for 5 days if somebody really has acute nociceptive pain, and we just do it in 5 days because those courses are every 5 days, every 3 weeks. But topical agents, including the Voltaren, but more appropriately, probably CBD creams, and we can give you a short list of national companies. But if you want to go with a local company, just make sure they're registered and certified, and get a broad spectrum and just slap it on. And we'll talk about that more with myofascial pain as we go on. And the companies, I'll just go ahead and mention, if you agree, are Charlotte's Web, Bluebird Botanical, New Leaf, NULEAF, and Lazarus. I think are some of the top ones, but there's hundreds out there. It's a multi-billion-dollar industry,
Yes.
The cannabis industry. But the topical CBDs tend to be helpful, and that's our go-to. Now, sometimes if it's just unresolved, sometimes we'll actually use a lidocaine patch, or I like to use lidocaine gel, as long as you're careful and wear gloves, you put it on, just to numb it up and give somebody relief for 4 hours when other things aren't working.
Mm-hmm.
The second type of pain we talk about is neuropathic, and JSC pioneered the use of dual neurotropics, and by neurotropics I mean seizure meds. Most people are familiar with Neurontin or gabapentin, that's one of them. We pick from a list of 6 or 7, I'll just list them, but we try to combine them. Neurontin and pregabalin, or Lyrica, work by inhibiting calcium channel release, which limits the firing of those particular neurons. The other four, lamotrigine, oxcarbazepine, which is trileptal, carbamazine, which is tegretol, and zonisamide, which is zonegran. We'll try to combine one from each group, or two from one group is okay too, and titrate up. So certain people have ceilings with certain meds, but if you titrate, I think we get synergy. And for the life of me, I don't understand why this hasn't been done before. We've been doing it for 15, 16, 17 years. It might be my AIDS background with combinations of things is working. But can't they understand that some of the neurology seminars and so forth are starting to do what we're doing?
They are, especially if they're trying to get away from the opioids that they were commonly using to prescribe for acute pain. They've had to start thinking out of the box and using their training.
Yeah, well, I guess they're in my box now.
Yes, they are. They're in our box.
They're in my box.
Yeah.
They got my box. And they'll never give me any credit for that box.
No.
That's okay.
No. Yep. It's okay. We're in it to help people, so.
So the third type of pain, and by the way, our patients usually have at least two types of pain, and many have three. So they hit the trifecta. And you're kind of getting the idea that each is treated differently, and there's no opioids used. Do you ever use hydrocodone? Rarely. Do we use tramadol once in a while? Yes, but not routinely. But no opioids, because they just don't work, and they have adverse effects throughout. We'll do other techniques, we're all for acupuncture and dry brushing and detoxing every way to help, and we'll get into the levels of toxin and expression. But for central pain treatment, many of you may understand there are ketamine centers popping up everywhere. The protocols for depression is one indication, the protocols for pain is another, and there's just a whole hodgepodge of protocols out there and ways to give it. We don't do it here because of liability reasons. I have to have an anesthesiologist or a nurse anesthetist here, and that's just not who we are. So we're not doing ketamine infusions, but we do use ketamine spray. Ketamine interferes with NMDA liberation of glutamate, which is the number one excitotoxin, the number one neurotransmitter that causes pain. And the reason it causes so much pain in our population is because they have damaged landscape. In other words, they have neural sensitivity, they have lower thresholds. So ketamine is one, but the first one is actually THC, which are marijuana friend. And there is a synthetic form of THC that's been around for decades for nausea, approved for nausea by the FDA. It's called Marinol. And that's a go-to medication I've been using for many years, including my AIDS patients. And it is great for nausea, but it also is a go-to medication which we titrate up for central pain. So it wouldn't be unusual to have somebody on a topical cream, a couple of neurotropics that we titrate up, and some Marinol with or without ketamine spray, which is another way to deliver that we can do. And then a third drug that people don't know about that we've used with some help in very low doses in combination with ketamine or Marinol, THC, is mirtazapine or Remeron, just in tiny doses. Now, most states, or half the states at least, are cannabis friendly now and have formularies. So when it comes to that, I just say, hey, go to the dispensary and just tell them what your situation is and get some sort of formulation that you like. I'm not crazy about vaping, but we have gel caps and drops and so forth and gummies. And if you like that better than Marinol for a THC source, that's fine. Also, some people use a topical cream with THC in it, which seems to help a little bit better, but not consistently. So we have all kinds of variations in that regard. But really, as far as the central pain goes, we have to get that under control, and we only have 2 or 3 go-to products right now, and so it can be really tough. So we cross our fingers that we're going to be able to control this, because it is the type of pain that you don't want to put your clothes on because it hurts. You don't want to go outside because the wind blows and it hurts. You don't like light touch. You're just in a torture chamber with this. And everybody who has central pain has the other types of pain, by the way.
Yes. So if we think about it from a PD perspective, what can we actually do? What meds can we use? Dr. J mentioned anti-inflammatories. topicals for the nociceptive pain, and we can use all of those. Again, we want to be really mindful of the gut so we don't enforce that we're using ibuprofen or things of that nature for too long a period of time, but in the instance that the pain is occurring, it can be very helpful. And when used for at least a week or more, that's where we really have the anti-inflammatory properties. Parents tend to really like the topicals as well, and I use it judiciously too, just for that same reason too. We can kind of use it more as needed. As we move towards the sensory or the neuropathic pain, the pain I discussed about the numbness, the tingling, again, we can also use some neurotropic agents for them, even synergistically, even at a younger age. I feel very comfortable monitoring those medicines. There are some that I stay away from that aren't appropriate just because of a child's paradoxical effect to these medicines, unlike which would happen for an adult. Children tend to also do very well with CBD oil, and I feel very comfortable using that, even in combination with something very calming like GABA, with L-theanine to be supportive for the nervous system. It's a calming agent. We can also use compounded neurocream for them as well. We just have to modify the dosages and modify some of the meds used. We work very closely with the pharmacist at Transdermal Therapeutics to compound these agents that can be used. And lastly, the central pain, or the more challenging pain to treat, even in our adult population, but even a little bit more difficult for our pediatric population, because obviously there's only certain things that we could use for them. And we have to be mindful of the ages in which we are using these agents. The first go-to often is CBD oil, because if it's full spectrum, it might contain a very small amount of THC, 0.3%, in order for it to remain legal, which can ultimately calm the central nervous system, providing them with some relief. We may also potentially use some of the mirtazapine too, as kind of a step up from there. And realistically, I'm very judicious about the Marinol. Again, at a particular age is absolutely appropriate, especially if they're in so much pain. Some children even report that if they have significant no-touch-me pain, let's say in their lower extremities or all over their body, it's even difficult to get into the shower or to bathe, because their body is also interpreting the temperature of the water very differently, and it's causing significant burning, significant pain, cold sensations, ultimately very uncomfortable. So again, we have to listen to clues from parents to cue into what type of pain they're having, and then ultimately what's an appropriate agent for them. We work together too to be thoughtful about what have our patients tolerated, what have they liked, what's worked for them. So all of this is about an art and a science when it comes to pain management.
Yeah, thank you. Thank you. Very much an art with science behind it. The science is lagging behind in this disease, obviously, and clearly. It's like 30 years behind, and it's billions of dollars behind compared to HIV/AIDS, for example. And I've said that. I said this 10, 15 years ago, and nothing has changed. It's really sad. So, Candy, I'm glad you mentioned the paradoxical effects of the neurotropics, because that is an issue. That can, well, first of all, people cannot tolerate some of the neurotropics I listed, and that's fine. So that's off the table. We just say, okay, that one's gone. And some people, unfortunately, can only find one of the group that they can tolerate, and we have to go with that, because otherwise they can't tolerate it. Although if we can find a second agent at a low dose, we'll go with that, hoping that we get synergy. And as time goes on, let's say months into therapy, paradoxical effects with neurotropics is one of our 25 roadblocks, which you've yet to publish, but it is. And so we have to think about that. If somebody starts going sideways after being stable for a long time, and they're starting to have also neurogenic symptoms and neuropsych symptoms and so forth, yeah, you have to consider that these agents are no longer your friend. And the other thing you said, had to do with the autonomic nervous system that affects not only your kids, but also our entire adult population. And that's complicating things, because some can't stand heat, some can't stand cold, and sometimes they have heat in one body that's intolerant part of their body that has a heat intolerant, another part that's cold intolerant, all at the same time. So the example would be, it's very hot around the world right now. You go outside and our patients may be chilling and cold, even with light clothing. So that's an example of that. I guess we should move on with other questions.
Yes, we have a few others, specifically more about what causes pain, and realistically, how can I reduce it? If medications aren't an option, then what can we use? And what means might be effective to kind of move the needle towards pain?
Yeah, so there's some symptomatic things you can do. First of all, magnesium is our friend. Magnesium comes in all sorts of salts. We like magnesium threonine because it does some nice things with the brain. But if you're constipated, magnesium citrate is our person. The rest are pretty much bowel neutral in that regard, magnesium malate. But lots of magnesium interferes with the calcium activation, and which discharges the nerve. So magnesium is our friend, and most of you know that are followed here that we check magnesium all the time. Red cell magnesium, RBC magnesium. We like it very high. The higher the better. I think topical evaporants, if you will, the camphor and things like that can be soothing. Some people go with that. But as I'm going to show later with our head and neck pain, we really resort to the topicals because no matter how good our neurotropic combos are, they're just not quite good enough.
Often we find that if we can be really thoughtful about the chronic inflammation in our body, in our patient's body, we can be thoughtful about reducing their pain too, because abundance of pain equates to systemic inflammation. And if we can be also thoughtful about perhaps any genetic mutations in the body, that might lead us to discover just how well this patient's reducing oxidative stress, how well they're detoxing intrinsically in their body, especially if they're having difficulty with doing forms of extrinsic detox, like Epsom baths, taking berberine panela drops, drinking good water, getting a sweat, and that's still not providing all the relief that they need.
Right, and there's evidence now that with epigenetics that we see multiple genetic changes with chronic pain, hundreds and if not thousands. And this is a recent discovery that, as we adapt to chronic pain, I mean, 24/7, especially with the central pain or CRPS regional pain, it's just, your life is intolerable. It's just, awful. And then you may have other types of pain as well. So the body and brain are trying to adapt. Now, remember, the brain is getting these signaling through the brainstem with our very important nuclei coming up from the dorsal roots of the spinal cord. Dorsal means in the back, ventral's the front. Ventral is always aimed at the belly button in the animal kingdom. So it's brainstem, nuclei is thalamus, which is our switching station for sensory input, except for the smell, except for the olfactory nerve. And the cortex, which is kind of made aware that, hey, I'm in pain, this hurts. And it may be an appropriate stimulus or may not be an appropriate stimulus, which is called allodynia.
Mm-hmm. Another thing to make mention of that can cause pain is we want to think about diet, right? What's inflammatory that we consume? We ultimately have control about what we put in our body when we're at the mercy of this disease. So we want to think about gluten, we want to think about sugar, we want to think about potentially dairy for some people. Largely histamine can also be an issue too. So being really clever about what patients tolerate food-wise, and if we can, keeping a diary of what they're seeing that are inflammatory for them, what's causing gut symptoms, maybe what's causing more pain, more inflammation in their joints, more headaches, all of those things that are pro-inflammatory. If we can control for them, then ultimately we can reduce some of the systemic inflammation that we've been talking about. It's not a perfect system, especially for my young pediatric patients, but ultimately I try to just be thoughtful about the ones that we know are causing the headaches, causing the discomfort in the abdomen, and then having parents be really thoughtful about restricting those things, or even at the very least modifying them so that they can see some notable improvement too. Because ultimately it can affect a child's mood too. Feeling unwell.
For sure. Oh my God. So I think you've all heard about my mood condo story. So on the first level, everybody's irritable, and we won't talk about the others, but because we already did that. Everybody's irritable.
Yes.
So the kids, oh my gosh, poor kids, you know, just irritable, not happy. As far as diet, so there are three main ways to detox, just broad categories. One, don't do a pro-inflammatory diet. That means gluten, gluten, gluten. No gluten, gluten, gluten. Okay, people always say dairy is the bad thing. Not necessarily. You know, you have to decide yourself whether you're intolerant of dairy. Sugar, let's talk about sugar and artificial sweeteners for a second, because that's important. Sugar, obviously, unfortunately, a lot of patients have cravings because of what's happening to the hypothalamus and the brain inflammation, and so they get cravings, and sometimes it's for things they don't like, but a lot of times, unfortunately, it's sugar. Too much sugar spikes the insulin, which increases glutamate in the brain, and that causes more inflammation, and so that's really, it make people wonky, which is a medical term that I learned a long time ago, wonky. You can find it, you can just look it up. And so that's a reason not to overdo it with sugar. Of all the commercial sugars, honey's probably the least provocative because it has the least amount of fructose, and
Yes.
but it's still
homeopathic properties too.
well, it does, yeah, especially
Some degree.
Manuka
Yes.
honey is good.
Yes.
But then I think you were also mentioning histamine. We're going to talk about histamine a little bit more in the future. So that reminds me, I wanted to talk about when we look at our patients, we're always thinking this, we're envisioning an inflammatory quotient. So, okay, some people say, why do I have a good day and then a bad day, or a good week and a bad week? Well, it's all where the inflammatory quotient is. How many toxins are floating around at any given time, attacking your vulnerable, damaged landscape, which is highly sensitized. It's the nervous system, okay? And so, again, you get the short straw on this because you're already inflamed. You can't tolerate the toxins other people tolerate. Plus, you can't detox as well for the most part, and that's a common theme as well. So it's all about the inflammatory quotient, and so that means if you've been bad with your diet, don't do that. Now, artificial sugars are what we use, as many of you know, to help melt the biofilm. They're very efficient. Sugar alcohols, they have an alcohol side chain. Very efficient. And we use xylitol, which is this chemical equivalent of, molecular equivalent of stevia. Stevia's in everything. Erythritol's in a lot of stuff. Xylitol's in a lot of stuff. We don't like the other sugar substitutes either, but probably monk's fruit as a substitute. If somebody wants to really go keto or something like that. So bottom line is, I'd rather have you have a little bit of honey than any kind of sugar substitute, because it melts the biofilm and we get microbial chaos. So those of you who've been through our treatments know that we do it in a systematic, coordinated way, so that we use the sugar alcohol and lactoferrin to help melt the biofilm as we treat, and then we stop that and we go ahead and treat and kill what comes out. So if you're melting biofilm randomly and chaotically, it's chaos. So if you're having sugar-free stuff all the time, that's not good. So that's the takeaway today as far as, where to control your inflammation.
Absolutely. Especially when we try to teach our patients to read labels. Know that these sugar alcohols can be hiding in things. I've found it in some of the pediatric supplements that we might even use to help with management of pain. Stevia can be hiding in them, so can xylitol as a way to flavor them and make it more exciting and appealing. But ultimately, it can make us feel poorly. So reading labels is ultimately very important, and can always report to us, I'm using this product, what do you think about it? Is it safe for me? Some of our patients are ultimately extremely sensitive to sugar. Some are mild to moderately, but again, if they could limit their consumption of it and use more natural means, that's a better substitute. Lastly, when we think about what causes pain, we briefly touched on LBC infection, but also comorbidities are things that can also be contributing factors from what we understand.
Yeah, I mean, if there's another inflammatory issue in the body, whether it's colitis or gallbladder disease or some sort of connective tissue disease, yeah, that contributes for sure. But the same principles apply. We need to lower the inflammatory quotient. We use judicious use of anti-inflammatories. whether it's Plaquenil or short courses of Toradol or occasional use of meloxicam, or ibuprofen. We're fine with that. But some of the natural products that probably have the best anti-inflammatory quotient would be curcumin, and resveratrol, but not for women so much, but resveratrol. And these are both dosed approximately 250 to 500 once or twice a day. Vitamin C, quercetin, and we have found a couple of other neuroprotective products, supplements that we like. One is called PEA, that's palmitoylethanolamide, PEA, easy for me to say.
Yes, it's a mouthful.
and luteolin, and we're looking for others. As you know, there are hundreds of products out there that have merit, but you know, we do have an issue of pill fatigue and diminishing returns. So you take 4 or 5 good antioxidants, and you're probably getting diminishing returns. We also talk about mitochondrial support, so we're looking at CoQ10 and carnitine from the very beginning, and we may be monitoring and supplementing in that regard.
And just to bring us back to what we focused on in the beginning about detox measures and how that reduces systemic inflammation, thinking about Epsom salt baths, those who are able to tolerate heat can advance to infrared sauna or perhaps steam, acupuncture, cupping have worked for some, even participating in things like yoga, range of motion exercises, getting the body moving. When we're in pain, we become more sedentary, body becomes more rigid and it's tight, and the more motion and activity we can do that's tolerable can be very helpful. And lastly, ultimately, treatment with oral antibiotics or IV antibiotics, if our patients are candidates for that, is what's going to get them the ultimate pain relief. But in combination with stabilization, with detox, all those are critical components.
Right. So with treatment, so we have to have our patients stabilized. We have to have the baseline at a manageable level. We treat gently. We don't torture our patients. But at some point, we have to kill the infections that caused all this in the first place. And we do. Fortunately, we take advantage of the long half-lives of the organisms that were targeted, so that we don't have to treat every day. In some ways, it's like chemotherapy in that you need a break. You know, after you've killed cancer cells, you kill some of your own cells as byproduct. You got all this waste to discharge, and that's the same thing that happens with this infection, because the spirochete, because of its coat, which is a lipoprotein rather than a lipopolysaccharide or teichoic acid, gram-negative bacteria, gram-positive lipoprotein. That's what Herxheimer is. That's why you have Herxheimer, and it's in the brain. It's in the spinal cord. It's in the peripheral nerves. So we're walking a relatively thin line, and it certainly supports the issue or the concept. Let's get our patients stabilized as much as possible. I've said it time and time again. If you don't sleep, I can't treat you. If your pain's unmanageable, I can't treat you. If you're off the reservation with your mood and it's destabilizing, I can't treat you. If you're in an adrenal crisis, I can't treat you. If you don't have support, I can't treat you. So we have to have these things in order before we can go. And then as we go, it's still a tough journey, but patients are encouraged and given a concept, and they're given a timeline. So it's like we do have a plan. It's not like, well, let's try this, let's try this, let's try this. We don't treat everybody the same, but we do have a plan. We have a very firm plan, which is modeling over time as we learn, as we get new information. I think the most recent thing 2 or 3 years ago was the histamine issue, which we ought to talk about briefly. And because it's a pro-inflammatory, it's not our enemy, it's our friend, but when it's in excess, it's pro-inflammatory. And we can see it. We can see people flush. We can see people have hives. We can see people, so I stroke Candy, I get a big red streak. She has dermatographism. So we understand that, and we have relatively effective ways to address histamine, which is not our friend, which is not our enemy, but it is pro-inflammatory. And it actually contributes to our wakefulness and alertness. That's why antihistamines, some of them, like Benadryl, make us drowsy.
Yes.
Are we ready to talk about antihistamines?
We could.
Or are we ready to talk about myofascial?
We could incorporate the myofascial part, then introduce the headaches.
Okay, let's talk about myofascial pain, which is brought about by repeated inappropriate neural discharge on the motor side to stimulate muscles that didn't need to be stimulated, causing contraction and ultimately lack of blood flow, ultimately scarring, fibrosis, and the fascia has nerve fibers. So we have all this inflammation, and so we have a different type of pain. And these are the knots you get in your back when you're sick or when you're not sick, and which have where the crunchies are, where it can be in the traps and the parascapular areas and in the neck, primarily in the paralumbar areas, also in the torso. But this is a second type of pain. So this disease is absolutely devilish because, you know, with the nerves on fire, it activates all this other stuff. It destabilizes us in so many ways, neurocognitively, emotionally, and so forth. And then on top of that, we got pain. We got all types of pain. We got different categories of pain. So for the myofascial pain, we talk about, first of all, heat.
Yes.
Heat, and then stretching, and then light massage, maybe heavy massage to break down the fibrous tissue.
Yes. Depending on what's tolerable.
Depending on what's tolerable, yeah. And so we have to have the nerve pain under control because it all came from the nerve to begin with. And then we'll slap some CBD on it. Some people use massage guns.
Yes.
And laser therapy, needle therapy, acupuncture is very beneficial. We're big fans of acupuncture because I think it resets the electrical grid. We're all electrical beings, and I think that's what it does. That's never been proven, but we know it releases endorphins, and particularly if the acupuncture therapist gets the vagal nerve here in the lobe of the ear, it can be very helpful. So we're all for that. Doesn't help everybody, but it helps a lot of people. So the approach to myofascial pain cannot be ignored, and so I call them crunchies, and I call them myofascial islands because we typically find them up and down the back, in the paraspinous, parascapular areas along the scapula, and then in the traps, which are here, trapezius, and the trapezius muscles, and the head and neck, which we're going to talk about in just a moment. And so this is more of a physical massage. This is where your chiropractor can help you if they're understanding, and you know they just should stretch you and put heat and massage out the crunchies lightly and then more firmly, perhaps.
Even some have benefited from the neuro cream too, if a family member
The
could apply that
neurotropic,
too.
well, the neurotropic cream, if you got a bad
It's
actor,
the skeletal muscle relaxant in it.
yeah, it does. So yeah, our neurocream has the compound that we use has like 7 things, including the ketamine. So, but if the nerve's hot, it should be addressed as well. So you're treating with cream up and down the spine,
Yes.
and then you're massaging the muscle. So you're treating with the cream up and down the spine wherever a hot spot is, and then so it's going to innervate here. So it goes like this. Can you see that? So our neural pathways don't go like that. They go like this. They sweep down. So if you've got a hot spot here, it maybe is activating a parascapular muscle here, and this is tight and crunchy. But the nerve needs to be addressed too with the neuro cream, and then use your CBD cream here after you've done the heat stretching or whatever else does work for you. So myofascial pain is very important, and we're going to talk about it a little bit more in the head and neck area because we're going to spend some time talking about headaches, and we have little time. We have enough time to do that.
Is now a good time to maybe do the demonstration?
Yes, I think so.
Okay.
So Candy has agreed to let me demonstrate to you, first of all, what our exam looks like and where we typically find neural-rich areas in the head and neck. So most of our patients have some sort of head and neck pain or headache, and there are several types of headache. Okay, first of all, there's a global inflammatory headache, which is your head's in a vice or your head's about to pop. And that, by the way, they can occur in combination as well. So you can have 2 or 3 types of headaches. But the global inflammatory headache, we believe, is excitation of the sac around, the thecal sac around the brain, which is where the nerve fibers are, the sensory fibers are. When that gets inflamed, your brain you feel like your brain is about to pop or explode. So the brain has no sensory fibers. So if you put a spike in the brain, it'll hurt going in, but it won't hurt when it hits the brain. That's a bad attempt at a joke, I'm sorry. But anyway, so the dermata is inflamed. And so we use things that help with glutamate, which we should get into. So since glutamate is the major excitotoxin. So theanine and taurine, which are amino acids, compete with the glutamine receptors. They're a good thing to try to use. Especially, it also helps with busy brain, which I think in large measure is glutamate induced. So we use a diamox or acetylceramide cocktail, which is a carbonic anhydrase inhibitor. It's been around for decades, mainly for glaucoma. We use it with a little potassium and vitamin C because it does tend to alkalinize the body. You can get tingles in the hands and feet. I would say it's effective taken once or twice a day for 75% of our patients. And then let's get into the cervicogenic headaches because they tie in with migraine and that sort of thing. So with Candy's permission, I'm just going to demonstrate what we do every day to evaluate our patient. Usually I do it from the front side, but you can see it over here better. And so under here, under the occiput, if you guys at home would just feel your own head, the occiput is here. So here's the first, this is the second cervical root. It's the first root with sensory innervation. It's right here, often tender. It innervates this, okay? And it innervates the part of the neck. C3 is next. It innervates this. C4 innervates the traps and does a little bit more. So 2, 3, 4 are often very tender. Then we have the semispinalis muscle. So if you turn your head to the side and stretch or clench, you'll see the prominent muscle here. There's a layer of muscles and tendon, but this is the semispinalis. And it is, so here we're talking about a myofascial equivalent, okay? So in our neck pain, we'll treat with neurocreme at C234, trying to block the neural output. And then, but here we'll do another technique. We'll do heat and stretching, and we'll put some CBD on the muscle that's been tightened because of repeated firing. Now, if you turn around just a moment, okay. So as I said, this is a target-rich area. So if you go an inch above the Adam's apple over to the thyroid, to the carotid bulb, the carotid artery, it bifurcates into the internal and external carotid. It is a neural-rich target. It's innervated by 4 fibers, including C2, the trigeminal nerve, the fifth nerve, the vagus, and the sympathetic plexus. And it is a baroreceptor and its target, and it can get very inflamed and very swollen here. And people, because it's so deep in the throat, people think, oh, I have a sore throat, and because it radiates here, they'll say I have an earache. So people are constantly going to their GP or ENT and saying I have a sore throat or earache, and everything looks fine. That's another target-rich area. And then finally, we have the trigeminal ganglia here, which sits over the TMJ. If you open your jaw, it's right there. You find it right there. We call it preauricular, in front of the ear. And if you tap this here, a lot of patients don't like that because it's inflamed, and it shouldn't hurt at all. And just tapping it will send pain. It has 3 divisions. So it has mandible, maximal, and ophthalmologic. And so you tap it here, and this innervates our teeth, by the way. So if you have dental pain, you can pretty much guarantee it's going on here. Now, what happens with people that have headache, especially behind the eye? Here's what's happened. Now, I'm not an electrician, but remember I said the C2 will fire off? I'm not an electrician. I don't want to be. I'm playing one now. All right, C2 does all this. So how come the head gets involved? Well, because I think there's excitation pathway where the threshold for firing off is lowered. So if this is really hot and fires, it may activate the fifth nerve, and now you got your eye involved and you got your whole face involved, if that makes sense. So we see that all the time. We call that cervicogenic headaches. We call it C2V1. Okay, C2 and then V for 5, the fifth nerve, and we just use the word 1, which is the ophthalmologic branch. So we see that all the time. So if we can block the pain here and here, we're going to help our patients. They're going to really like it. And I would say 80% of patients tolerate the cream just fine. Thank you, Candy.
You're welcome.
For being a good sport.
You're welcome. This kind of leads us to migraines.
Well, yeah, why don't you take off from the migraines, because the histamine and you have more experience with neurotech and things like that.
Absolutely. So with migraines, they're very complicated to diagnose, very hard for patients to describe to us, very difficult for the pediatric population to explain it, and it becomes kind of an issue too about how we even manage it. Some of our patients will have, especially the pediatric population, a PD neurologist who maybe has already trialed them on medicines. They're trying to work and take care of things that could be causative agents. One of them that we find as an abortive agent that can be very helpful is 𝗧𝗜𝗃, which is kind of new on the market. It actually is an antagonist to CGRP receptor, which they're finding now has quite an impact on what's creating a migraine, as much as histamine can do as well too. Other agents we're using now are sub-Q injections like Emgality, which is really the injectable version of the CGRP. When we think about histamine, just as Dr. J mentioned, using things that will mitigate those include antihistamines, like a common 𝗧𝗜𝗃 or hydroxyzine we often use, or 𝗧𝗜𝗠𝗏, vitamin C, taurine, GABA with L-theanine. These are all things that have the propensity to not only reduce glutamate, some also reduce histamine, but we can put a combination. If you add a neurotropic agent like Lamictal, you've covered a lot of your bases too. Or other agents that we might use that honestly can also work on histamine too, that are prescribed sleep agents like 𝗧𝗏𝗏 or perhaps trazodone too. So we try to be very thoughtful about who our patient is, what their needs are, and medications, again, that we can use to work synergistically, not only for pain, but for sleep, for mood, antihistamines too, in a combination, and be really thoughtful about what are the variables contributing to their type of headache they're having. And those are only two that we've spoken about.
You also have the
multiple.
cromolyn sodium class, the
Yes.
glucotrione inhibitors,
Yes.
and the mast cell inhibitors. And
Absolutely.
so mast cell to me is kind of a trendy diagnosis, and people say, oh, all of a sudden, why would people all over the world all of a sudden have mast cell? So the common denominator is LVC in my view, and I'm not putting those people down, don't get me wrong, but we look at mast cell, actually when a patient has a histamine problem, we look at it as an opportunity. We can block that, and most patients can tolerate the range of things we do. We start with the H1, H2 blockers, so 𝗧𝗜𝗃 or Allegra, and then Pepcid over the counter, and DAO, which diamine oxidase, which breaks down histamine in the gut, which most histamine is made in the gut. Histamine-rich foods, we just let our patients know what they are, and we don't say avoid them entirely. We just, cut back a little bit. And it also sometimes we'll double up and just say, okay, take some Atarax at bedtime, or sometimes Benadryl, and that gets them to sleep because it breaks the histamine alertness, excitatory property. And so we rather than use the benzodiazepine like Ativan or Valium or something like that, and we'll take advantage of that, and it often works quite well.
Yes, we can be very clever about doing
Yeah,
so.
we're very clever. I don't know if that's the right good word.
And just very briefly, because this is trending, and an important finding that we're noting has a critical impact on our patients is more the craniocervical instability and CCI.
Yeah,
Just very briefly to touch on, if we
Well,
have time.
we don't have time, and that's very complex and very big. So we're going to sign off. And thank you very much for looking in, and please send us some questions, and look forward to having a session with you next time, hopefully next month. We'll let you know. Take care, and God bless.
Thanks for tuning in. Take care.